Colorectal cancer by me and Kat. Colorectal cancer is the third most common form of cancer. It is responsible for 9% of cancer deaths. CRC is more common in men than in women. The risk of CRC increases with age. About 90% of new CRC cases are detected in people older than 50. The incidence of CRC in individuals over 50 is decreasing due to increased screening to detect precancerous lesions. Risk factors for CRC include diet high in red meat, obesity, physical inactivity, alcohol, long-term smoking, low intake of fruits and vegetables. About 1/3 of cases of CRC occur in patients with a family history of CRC. Adenocarcinoma is the most common type of CRC. Typically, it begins as an adenomatous polyp. Approximately 85% of CRCs arise from an adenomatous polyp. As the tumor grows, the cancer invades and penetrates the mucosa. Eventually, the tumor cells gain access to the regional lymph nodes and vascular systems and spread through distant sites. Here we have the colorectal cancers in different stages, stage 0 being in situ, and stage 4 being a metastasis to a distant organ. Here we have the 4 locations in which colorectal cancer can arise from, starting from ascending colon, transverse colon, descending colon, and the rectum, each with their own set of signs and symptoms. For our case scenario, we have Ed. Ed is a 64-year-old white male of Irish descent who started having frequent episodes of constipation. This symptom prompted Ed to see his primary care doctor. Blood work indicated that Ed was mildly anemic. The rectal examination and fecal occult blood tests were negative. Ed was advised to schedule a colonoscopy as part of the workup for constipation and mild anemia. Ed scheduled a colonoscopy for the following month. However, 1 week later, Ed had excruciating abdominal pain and severe constipation, which prompted him to go to the emergency room. He was subsequently admitted for evaluation and treatment. Computed tomography scan and magnetic resonance imaging of the abdomen and pelvis revealed a mass in the sigmoid colon, diffuse metastatic disease in the right and left lobes of the liver, and retroperitoneal lymphadenopathy. Colonoscopy revealed a completely obstructing 2 cm circumferential mass in the sigmoid colon 20 cm from the anal verge. Biopsy was taken and ultraflex precision colonoscopy stent was placed in the colon stricture. Ed was placed on a low residue diet. The colon biopsy was positive for a poorly differentiated adenocarcinoma. A fine needle aspiration biopsy of the large liver lesion was positive for metastatic adenocarcinoma. Ed's past medical and surgical history is unremarkable. His social history is significant for smoking 1 pack per day for 35 years and occasional intake of alcohol for social occasions. He is married and has 4 adult children. Family history is significant for a sister diagnosed with colon cancer 2 years ago prior at the age of 50 who is currently alive with no evidence of disease. Ed had consultation with a medical oncologist prior to discharge who explained that he has stage 4 colorectal cancer, which is not curable at this time. The goals of therapy are to manage symptoms, prolong survival, and maintain quality of life. The oncologist recommended that Ed receive systematic chemotherapy utilizing FOLFOX. Ed was sent to interventional radiology to have a central venous access port implanted and saw the medical oncologist a week later. So this case scenario might seem like a lot to take in and there's a lot of words, so we'll break it down to the most important parts. Okay, so here we have all the important parts. So all of this will be included in the concept map, try to make the mental connections and how these are all connected to colorectal cancer, and Kat will be explaining the pathophysiology and nursing management in taking care of a patient with colorectal cancer.